I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our moderators, Dr. Aniket, Dr. Sudeep Khanna, and Dr. Akash Rai, to start this session. Thank you, and over to you, sir.
I think the first topic for today is post COVID liver injury and SARS-CoV-2 infection and liver involvement. So I would request Dr. Sudeep Khanna, who is the moderator for this session, to take over and that we can start the presentation.
Thank you, Dr. Akash. Good evening, everyone. Today, Ajay will be speaking briefly on COVID-19 infection and liver involvement during the active infection period and post-infection when patient has cleared the virus and has even gone home. What have we learned and what are we still learning? So without further ado, I would request Ajay to please start his presentation. Ajay, please do.
Good evening, everyone. I'm presenting seminar on SARS-CoV-2 infection and liver involvement, presented by me, Dr. Ajay Jolly, DNB Gastro Resident at Apollo Hospital, New Delhi. My moderator is Dr. Sudeep Khanna, DM AIMS, Senior Consultant at Apollo Delhi. Introduction, COVID-19, severe acute respiratory syndrome coronavirus 2. Its severe form is characterized by respiratory failure and hyperinflammation with potential progression to multi-organ failure. Advanced age, obesity, cardiovascular disease, hypertension and diabetes have been linked with poor clinical outcomes in patients with COVID. CLD have comorbidities like obesity, diabetes, and cardiovascular disease, which overlap with COVID risk factors, potentially predisposing to more severe disease through synergistic effect. Hepatotropism of SARS-CoV-2 virus, cholangiocytes, angiotensin converting enzyme 2, ACE2, act as a receptor for SARS-CoV to enter the host cell. In healthy liver, the highest expression of ACE2 receptors appears to be in biliary epithelium. In vivo, electron microscopy shows intracellular virus particles within the hepatocyte associated with mitochondrial swelling, cell membrane destruction, and dilated endoplasmic reticulum, which strongly suggesting direct cytopathy of COVID in hepatocytes. Pre-existing liver disease is associated with increased expression of hepatocyte ACE2, thereby increasing the entry potential of COVID virus into the hepatocytes. This increased expression of ACE2 is thought to be an injury response to liver fibrosis. Mechanism for exaggerated COVID liver injury is underlying CLD is due to greater burden of hepatocyte infection and consequently widespread hepatocyte cell death. COVID-related liver injury in absence of chronic liver disease. COVID liver injury shows predominant hepatocyte rather than cholangiocyte cell death. Liver injury in COVID may be reinfection of severe form of the disease with systemic inflammation or in some cases a degree of underlying CLD. COVID virus in the lungs trigger ischemia, hypoxic damage as a result of pneumonia. Antiviral response is disproportionate at times and results in overactivation of immune cells and subsequently hyperproduction of cytokines, that is cytokine storm. Increased circulating cytokine like IL-16 are associated with development of liver injury, which is exacerbated by direct cytotoxic effect of COVID virus on the liver and by the hepatotoxicity associated with COVID treatment. Diagram represents COVID virus entry into the lung, which causes ischemia, hypoxic damage. Direct cytotoxic effect may occur on liver, which may cause Dili also. Liver damage may occur in form of increased ALT, AST, LDH. Immune cell overactivation can occur and thereby lead to cytokine storm. Mostly IL-6 is the main caused factor. COVID infection on the background of the CLD, cirrhosis and ACLF. Cirrhotics are at a greater risk of acute hepatic decompensation upon COVID infection. Weaker response to the vaccine result in lower level of circulating antibodies against COVID and have increased expression of ACE2 on hepatocyte membrane. ACE2 is not typically expressed on the surface of healthy hepatocyte, but has elevated expression in cirrhosis, permitting entry of COVID virus into the cell. Cirrhosis is associated with low level of circulating gut-derived bacterial products, which predispose to systemic inflammation and upregulation of inflammasome pathways. This results in sensitization of hepatocytes to COVID infection and lead to pro-inflammatory death and immune response. Diagram represent cirrhosis, uh, which leads to upregulation of systemic inflammation, leading to activation of inflammasome pathway. Other pathways increase expression of hepatocyte ACE2. And the last one is cirrhosis associated immune dysfunction, which leads to defective vaccine response, which ultimately leads to greater burden of hepatocyte infection and cell death, causing acute hepatic decompensation and ACLF. Drug-induced liver injury, Dili. It is a further potential mechanism for transaminase elevation in COVID infection, either as a consequence of drugs used commonly in critical care or antiviral drugs. Lopinavir, ritonavir, even in low dose boost regimen, can develop hepatotoxicity and should be used with caution in CLD. Both remdesivir and tocilizumab have reported to contribute to raised liver enzyme levels in 10% of cases. Unlike the typical respiratory presentation in non-cirrhotic individuals, Asian data supports a presentation with acute decompensation or acute or chronic liver failure in 20% of cirrhotic patients. Europe data supports a presentation with acute decompensation in 46% of cirrhotic patients with COVID-19 infection, with around half of these progressing to ACLF. Hepatocyte cell death is a key feature of the progression to acute decompensation or ACLF in cirrhosis. Exaggerated release of inflammatory cytokines and the activation of inflammasome pathways in the target cells are triggers for cell death following COVID infection. Inflammasome pathways has been shown to be upregulated in hepatocyte in cirrhosis, and hence the liver is pre-sensitized to injury and cell death during COVID infection and cirrhosis. Activation of pro-inflammatory caspase and cell death executionary protein gasdermin D, which facilitates cytokine release and may predispose to acute decompensation or ACLF. Alcohol-related liver disease. Pre-existing ARLD has been linked to adverse outcome in patients with COVID-19 infection. Comorbidity such as malnutrition and metabolic syndrome are present in ARLD and are linked with poor clinical outcome in patients with COVID-19 infection. Importantly, alcohol affects many organs, including the immune system, enhancing a pro-inflammatory response and susceptibility to viral and bacterial infection. Risk benefit of steroids should be assessed based on the severity of both alcoholic hepatitis and COVID-19 infection. Autoimmune liver disease. The effect of AILD on COVID-19 remains unclear. Steroid alone or combined with azathioprine is first-line treatment for AILD, both of which may predispose to viral infection. Similar prevalence in immunosuppressed AIH versus general population. American and Europe study from 34 centers showed specifically compared to patients without AIH. Patients with AIH did not show higher hospitalization rate, need for supplemental oxygen, and or all-cause mortality. Immunosuppressive therapy pre-existing AIH does not show worse outcome in severe COVID. Maintenance of immunosuppression during COVID infection was not associated with poor prognosis. Non-alcoholic fatty liver disease, NAFLD. It is associated with higher risk of progression to severe COVID-19 infection, higher likelihood of abnormal LFT from admission, and longer viral shedding compared to patient without NAFLD. High FIB4 score correlates with higher severity of COVID-19 infection. Hepatitis B virus infection. In Chinese retrospective study of 347 patients, neither the probability of severe COVID-19 nor the time to clearance of COVID differed between patients with and without HBV. On the contrary, second retrospective study carried out by Chen et al. Found that HBV patient had significantly higher mortality compared with patient without HBV infection. Hence, the larger prospective studies accounting for severity for underlying liver disease are required to determine the impact of HBV infection on COVID-19. COVID-19 and chronic hepatitis B virus co-infection that is HBsAg positive and HBV DNA positive, have increased risk of HBV reactivation regardless of corticosteroid use. Risk of HBV reactivation in patients with resolved HBV, majorly HBsAg negative and anti-HBC positive, that is total core positive, was low despite use of immunomodulators. Antiviral therapy amongst HBV patients was not associated with reduced mortality, hospitalization, or rate of ICU admission compared to patients without antiviral therapy. Antiviral treated group showed higher proportion with progression to liver failure than their counterparts. This group had a higher proportion of cirrhotic patients, which is a major co-founder. Therefore, it remains unclear if there is independent effect of HBV antiviral on COVID progression. Hepatitis C virus infection, US-based retrospective study, HCV infection was significantly associated with both higher rates of in-hospital mechanical ventilation and increased all-cause mortality compared to patients without HCV. A further US-based study showed contrary results using HCV patient and HCV negative controls, finding no difference in ICU admission or mortality. Therefore, currently, it remains unclear if HCV has disease-modifying effect on COVID infection, and further large studies are required. Hepatocellular carcinoma. In a study of 745 patients with COVID-19, presence of HCC was not independently associated with mortality compared to patients without HCC. By contrast, a more recent study of 867 patients demonstrated in a different cohort that HCC is an independent predictor of death in COVID patients. Possible reason for this difference relates to the size of the cohort. Fewer HCC cases in second study, a multi-centric US-based cohort second study versus a multinational registry with potential greater heterogeneity. Post-liver transplantation. Management of liver transplant patient during COVID infection was challenging due to the need for immunosuppressive therapies. Rabi et al. Evaluated this in 112 liver transplant patients, showing that after adjusting for age, sex, ethnicity, race, comorbidities, immunosuppression, and time since transplantation, presence of liver injury was independently associated with both higher risk of ICU admission and higher mortality. The COVID Hep and Secure study showed cirrhosis study showed that liver transplant did not significantly increase the risk of death. Immunosuppressive therapy was not a risk factor for mortality, unlike age, serum creatinine concentration, and non-liver cancer, which were associated with death. In Apollo Hospital, New Delhi, immunosuppression like CellCept and Pangraft are continued after liver transplant without dose modification. COVID-19 vaccination in chronic liver disease and liver transplant recipients. Recent data on COVID vaccination suggested decreased efficacy and durability of protection in cirrhotic patients. In US, 20,037 cirrhotic patients who received at least one dose of COVID-19 mRNA vaccine demonstrated delayed and reduced protection from COVID infection in cirrhosis compared to previously reported data in healthy individuals. Degree of protection was further reduced in decompensated cirrhosis, that is 50%, compared with decompensated cirrhosis, compensated cirrhosis with 66%. Immunogenicity amongst liver transplant recipients were reduced compared with controls, with significantly lower antibody titer 10 to 20 days after receiving second vaccine dose. US cohorts data of 79 patients with cirrhosis demonstrated that cirrhotics have significantly lower anti-spike serological response compared to control. Post-COVID-19 cholangiopathy, a novel entity. It is characterized by marked polycysts associated with jaundice that persist long after pulmonary and renal recovery. Mechanism is combination of bile duct ischemia, changes in bile composition, and biliary infection leading to cytokine storm, and contributes to the development of toxic bile and then cholangiocyte necrosis. Hepatocyte receives a dual blood supply from portal vein and hepatic artery. The biliary epithelium receives its blood supply solely from peribiliary plexus. Cholangiocytes are more susceptible to ischemia than the hepatocytes. When ischemia of the biliary epithelium occurs, blood supply to the bile duct is reduced, causing necrosis and sloughing of the biliary epithelium and bile cast formation. Biliary secretion of bicarbonate via transporter ion exchanger 2 forms a protective alkaline bicarbonate film on the apical cholangiocyte membrane as defense strategy. 3 patients of severe COVID-19 cholangiopathy had features similar to secondary sclerosing cholangitis of critical ill patient SSC CIP with histology of severe cholangiocyte injury and intrahepatic microangiopathy suggestive of direct hepatic injury from COVID. Bile duct paucity and cytokeratin 7 metaplasia of periportal hepatocyte characteristic of obstructive cholestasis and evidence of bridging fibrosis all indicate a risk of progression to SBC. All 3 liver biopsy lack the portal tract edema and neutrophilic inflammation characteristic of biliary obstruction. Diagnosis is by ERCP or MRCP revealing diffuse strictures and dilatation of IHBR with filling defect caused by presence of biliary cast. Hypotension occurs, so dopamine is given as it has positive effect on liver perfusion, contrary to epinephrine and non-epinephrine, which are thought to have a negative effect on splanchnic blood flow. Adverse prognostic factor includes associated renal failure, arterial and venous thromboembolism, rapid deterioration to liver cirrhosis, high MELD score. Without liver transplant, the median survival is 12 to 44 months. Conclusion: liver involvement is a common feature of COVID infection that can affect COVID-19 prognosis. The most current data are accrued from retrospective studies. It appears that patients with cirrhosis, ARLD, or NAFLD are at a significantly increased risk of severe disease, while the impact on patients with ALD, HCV, or HBV infection is less clear. Although the COVID-19 vaccination program, emerging data suggests that decreased efficacy of COVID-19 vaccines in patients with cirrhosis and more robust data are needed. Further public health recommendations or research strategies addressing COVID-19 and liver disease may be formulated based on fundamental epidemiological data provided in this review. Thank you.
So do we have any questions in the chat box? I don't see any questions.
Even I don't see any question as of now.
Okay, just a couple of questions from my side is that now there's a lot of data about what exactly are the histological findings. Initially, what we did not get was a lot of histology, that was the data was not there. But now we have got consequent data about the individual histological findings that happens in patients with liver disease vis-a-vis who do not have background liver disease. So could you throw some light upon that?
Basically, sir, there is a bile duct paucity occur, decreased formation.
Overall, not specifically on post-COVID cholangiopathy, overall.
Basically, sir, it leads to cholestasis and ongoing jaundice. If there is pre-existing CLD or NAFLD or cirrhotic patient, there is also worsening of AST and ALT occurs, which is mild to moderate. Only in 3 cases of post-COVID cholangiopathy are seen, which ultimately leads to liver transplant as an indication. Otherwise, they were managed better.
Dr. Kash, here I would like to add, basically, the most common features in liver involvement secondary to COVID would include absence of significant biliary tree or vascular damage, mild or maybe absent lymphocytic hepatitis. There is some activation of Kupffer cells, lot of regenerative hepatocellular changes, some fat deposition, steatosis, ectasia of sinusoids, and microthrombosis and acinar atrophy. These are the common autopsy findings which have been found out. Whatever I have read.
Yes. That's possible. Some of the things are whether these were due to COVID or these were just incidental findings and it was due to. So we'll never be able to actually, because we can't have prospective data to find out those things. So it will always be a debate on that. For post-COVID cholangiopathy, is there any specific algorithm for management and diagnosis?
Uh, Mostly said routine tests, LFT would be done. MRCP suggests a diffuse stricturing and dilatation of IHBR and presence of biliary cast. So they are, sir, mostly managed with as a therapeutic also like ERCP, and uh, dopamine is given. There is mostly hypotension is seen, so dopamine is given, which increases splanchnic perfusion. Uh, and if patient is still deteriorating, will ultimately leads to liver transplantation. Mostly it is seen with increased creatinine, increased age, high med score.
So you mentioned about the dopamine thing about liver perfusion with dopamine being higher. Could you just elaborate on that once?
Yes, sir.
You mentioned about the dopamine thing about dopamine having a higher liver perfusion. Could you just elaborate on that?
Uh,
What's the
study that,
mechanism?
uh, sir, basically dopamine act on D2 agonist. It basically increase uh, splanchnic blood flow.
Dr. Kash, basically use of dopamine ICU setting in patients with COVID and liver involvement would not lead to as much reduction in liver perfusion as would epinephrine and norepinephrine, because they would constrict the splanchnic vessels more as compared to dopamine. So dopamine should definitely be used in patients who have COVID and are have ischemia or are in septic shock, along with if one has to use epinephrine or other inotropes. So dopamine is safer as far as preventing ischemic injury to the liver and bile duct is concerned.
So I think we have got a few questions in the chat box. First one is from Atif. It's ALF in COVID. So would you
There
like
have
to take
been
it up?
there have been few case reports of acute liver failure in COVID, and but still again the point here is, was COVID responsible for ALF, or was it actually not ALF? Was it acute on chronic liver failure, which we know is not uncommon?
Yeah, absolutely, agreed on that. It would be difficult to prove whether COVID per se would be the trigger for acute liver failure. Uh, it says, in a patient with no existing liver disease, does LFT alteration relate to prognosis or severity? This is from Dr. Kunal Kumar Gupta.
It would be difficult to know, if the patient actually had underlying liver disease, short of, imaging showing us that yes, the patient does have underlying significant liver disease, because in any case, fibroscan done in these patients probably would be falsely high, because there would be some amount of ongoing inflammation in these patients, and some of them may even be in shock. So, it would be again difficult to say, but yes, if the liver is normal, otherwise prior to the disease, and some derangement in LFT is unlikely to alter the prognosis. Unless, due to drugs, subsequently it becomes a significant drug induced liver injury, but not in the immediate uh, time frame of acquiring infection and getting admitted in the hospital due to various other things. So personally, I don't think an altered LFT on a normal liver has much of a prognostic significance.
So we got one more, that any contraindication for COVID vaccine in decompensated cirrhosis patients and post liver transplant.
See, we definitely need more trials. They're very small numbers, but as of now, there's no contraindication. Unless of course patient has a lot of inflammatory activity ongoing. Suppose patient has active acute on chronic liver failure, you're not going to vaccinate them. The patient has to be stable, compensated or decompensated cirrhotic. That is most important, because vaccine is going to stimulate the immune system. We don't want the immune system to be stimulated when it's already in the phase of stimulation. But as far as efficacy is concerned, we need more trials. We're very small numbers which we know of.
True. I think the data is just coming out from most of the centers about the efficacy. Not bad data. It's like I think in India also there are some couple of data is already there, which shows good responses and as mentioned in stable decompensated cirrhosis and patients with compensated cirrhosis. So again, the same question. I think we have already answered this about dopamine rather than or epinephrine in ischemic hepatitis. And there's Dr. Manmohan who's asking COVID vaccination and portal vein thrombosis. So I think he's asking about any association between COVID vaccination and portal vein thrombosis.
Ajay, any thoughts?
Sir, actually data is less, sir. We can't comment on that. But we haven't seen any thrombosis cases with vaccination. Hypersensitivity is a contraindication, but no, as such, we have found portal vein thrombosis associated with vaccination.
So here I would like to say, I don't know about Covaxin, but definitely with mRNA vaccines, I think 2 or 3 case reports are there. But again, it's very difficult to say whether it's vaccine induced or not, and what is the underlying coagulation status of the patient. One should not forget, thrombosis occurs most of the times when there is some factor deficiency or too much of procoagulant factors. And all these vaccines are emergency use vaccines. They are not the optimal vaccines. So yes, it is possible. It cannot be 100% ruled out, but at the end of the day, one has to look at all the pros and cons, and all said and done, all the vaccines combined have saved a lot of lives. And we in our hospital have after Covishield have had doctors going in developing GBS and other neurological illnesses. It's not that they haven't. So, and it looks like vaccine has some role to play, but it is what it is till the time we have safer vaccines.
Yes, true on that. It's difficult to find whether it's actually causality or it's just a coincidence. There were recently lots of report about vaccination-induced autoimmune hepatitis with the mRNA vaccines. I think recently an Indian case report also came out. But with such a large population being vaccinated, it's very difficult to ascertain whether it was due to the vaccine itself or it was just bound to happen that time. So I think if there are no further questions, we can move ahead to the case.
So the case is being presented by Dr. Narendra, who was our DNB fellow, and will be moderated by Dr. Aniket, who's now working with us in our transplant unit. Over to you, Narendra.
Share the screen, Dr. Narendra.
Yes.
Click on slideshow.
Is my slides are, I think my slides are
Yes, you may start.
Good evening, everyone. Myself, Dr. Narendra Nagre. I'm a DNB resident second year from Indraprastha Apollo Hospital. I'm presenting a typical case, and my moderator is Dr. Aniket Bharadwaj. He is a consultant in Indraprastha Apollo Hospital. A 60-year-old male is a retired accountant, is a resident of Gangtok, Sikkim, admitted in Indraprastha Apollo Hospital with chief complaints of yellowish discoloration of eyes since last 10 days, rash all over bodies since last 5 days, and he also had history of fever since last 1 day. Patient was apparently alright 10 days back when he noticed yellowish discoloration of eyes, which was insidious in onset, progressive in nature, and associated with discoloration of urine. It was also associated with pruritus and clay color stool. He also complained development of erythematous rash, which started over the abdomen and later on progressed to involve upper limb and lower limb also. He also gave history of associated skin peeling. These were the picture taken after the admission of patient. These were not the actual picture on the day of admission. This picture showing the skin peeling and initially the rash was started over abdomen, but when this picture were taken, the rash over abdomen was subsided. He denies history of abdominal pain, vomiting. There was no history of hematemesis or melena. There was no history of ascites, altered sensorium. He denies history of intake of herbal medication or over-the-counter medications intake. He denies history of joint pains. There was no history of blood transfusion, drug abuse, or history of needle prick injury. He is a known case of diabetes mellitus since last 2 years, and he was recently detected as having bipolar disorder two months back. There was no family history of any liver disease in the family. He used to take beer only one can once or twice a week. That was not a significant amount, and he used to take tablet Janumate, which includes sitagliptin 50 mg and metformin 500 mg once a day. And he was started on the tablet Valproate 500 mg 2 months back, but which was changed to tablet lithium 1100 milligram OD 20 days back. On examination, patient was conscious, oriented. His weight was 56 kg and height was 174 centimeter. His BMI was 18.6 kilogram per meter square. On examination, he was afebrile. Pulse rate was 72 per minute. Blood pressure was 100 by 70 mmHg, and the right upper limb in supine position. Respiratory rate and JVP was within normal limit. There was a icterus present and a bilateral pededema was present. There was no history of pallor, cyanosis, or any lymphadenopathy, and there was no stigma of hepatocellular failure. On systemic examination of oral cavity was within normal limit. While per abdomen examination on inspection, the abdomen was flat in shape, umbilicus was inverted and seems situated midway between GP sternum and pubic symphysis. There was a erythematous rash seen all over the abdomen, and there was no scars, dilated veins, or hernia. On palpation, liver was palpable 4 centimeter below lower costal margin, and it was non-tender, firm in consistency. It has smooth surface, and the liver has a regular margin. Spleen and gallbladder was not palpable clinically, and on percussion, liver span was 15 centimeter. On the day of admission, his LFT was showing total bilirubin of 7.2, out of which direct bilirubin, sorry, it wasn't 2.7, it was. So it was mainly direct bilirubinemia. I think I put it wrongly. And AST and ALT was raised. It was 91 and 156, while ALP was 590. His RFT was within normal limits on the day of admission. Considering his history of yellowish discoloration of eyes, erythematous rash, and the history of fever, we have done investigation which were malaria and dengue was negative, while IgM IgM antibody for leptospira and the rapid typhoid test was negative. To rule out sepsis, procalcitonin was done and blood culture and urine culture was done, which showed no growth, while procalcitonin was 0.9. While doing all the viral markers were done, which were negative, including HbSAg and total core antibody, anti-HCV and HAV and HEV IgM antibodies. While ANA was negative, but his serum IgG level was increased, which was 2,256. while serum ceruloplasmin level was within normal limit, while anti-smooth muscle antibody and anti-LCM antibodies were negative. His urine routine microscopy shows 2 to 3 RBCs were high power filled, while there was a trace proteins present in the urine routine. His abdominal ultrasound shows hepatomegaly with grade 1 fatty liver. Subsequently, CT scan liver triple phase was done, which showed normal hepatic parenchyma with splenomegaly and distended gallbladder with diffuse mural thickening of GB wall without calculus. Chest X-ray was done to rule out any consolidation. It was on chest X-ray there was no abnormality, while 2D echo shows left ventricular ejection fraction 60%, and there was no regional wall motion abnormality. Herpes IgM and CME RT-PCR was done, and it was negative. Considering his cholestatic pattern of LFTs, we have done Montu test to rule out TB, and it was negative. UGI endoscopy was done to rule out any portal hypertensive changes, and it was suggestive of only gastritis. Subsequently, as medication was already stopped before the admission, and the LFT was showing worsening trend. So worsening trend over the days of admission. We have plan for ultrasound guided liver biopsy under the coverage of FFP, and the liver biopsy shows the liver section shows 6 to 7 portal tracts with hepatocytes showing focal mild hepatocellular cholestasis with mild to moderate inflammatory cell infiltrates in portal tracts. There was also presence of mild interface activity, and the inflammatory cell infiltrate consist of lymphocytes, predominantly eosinophil and occasional neutrophils. And there was a possibility of drug-induced etiology was favoring over autoimmune hepatitis on the basis of liver biopsy. This is the section showing liver biopsy. It is stained with the Masson's trichrome stain, which stain the collagens. These were the predominant eosinophil showing the invading the hepatocyte, and there is no definitive interface hepatitis here, but there were mild interface hepatitis. This is the another slide showing predominantly eosinophil infiltrates, and patient was started on the steroids, and he showed the gradual improvement after starting steroids, such as on 29th AST was 203, while it started decreasing since 29 July. Sorry, it was 29/7. Sorry, AST and ALT along with ALP and GGP start decreasing, but the extent of reduction was slow. On the day of discharge, actually this patient took discharge on request, and on the day of discharge, his LFT was showing total bilirubin of 1.7, direct bilirubin was 1.5, AST and ALT was 56 and 84, alkaline phosphatase and GGTP was 276 and 341, which was showing decreasing trend, and INR was 1.1. So my diagnosis is acute liver injury, likely drug-induced liver injury. And there is a term known as DRESS, or as drug reaction with eosinophilia and systemic symptoms. Actually, the diagnosis of DRESS is extremely challenging, and it is a severe idiosyncratic drug reaction with long latency period from 2 to 8 weeks. It manifests as fever, rash, lymphadenopathy with wide range of mild to severe systemic presentation, such as hepatitis, pneumonitis, myocarditis, and nephritis. Hepatic involvement in the form of hepatocellular necrosis was most common visceral abnormality. Most cases show spontaneous resolution with the stopping of impending drugs, while mortality is estimated to be around 10%. Most common drug involved in the DRESS syndrome are anticonvulsant, minocycline, allopurinol and abacavir and nevirapine is of nevirapine. Okay. Thank you.
Okay, I think you've already discussed about the entire case. I think we just go back a little bit since this is a case when before you had your physical examination findings. What were your differentials with the presentation per se?
Sir, on the basis of presentation, I have made the differentials of acute viral hepatitis, autoimmune hepatitis, and the drug-induced hepatitis.
So you said it was a cholestatic jaundice, right?
Yes, sir.
So how would you explain autoimmune hepatitis presenting as a cholestatic jaundice?
Sir, actually, the presentation was jaundice and the rash, and that's why we have made the provisional diagnosis of autoimmune hepatitis.
No, but you
At
said
that time,
there was pruritus, right? You said there was a
Yes.
classical history of pruritus and clay-colored stool. So if somebody is coming with clay-colored stool and pruritus, where you're saying it's in cholestatic jaundice, why is autoimmune hepatitis so high in your diagnosis?
Narendra, Dr. Akash is asking you, even if you keep AIH, would you want to bring something along with AIH?
so
Again,
drug-induced autoimmune hepatitis.
Part of AIH, part of autoimmune, but not AIH.
Any overlap, basically.
O-
Any overlap.
Overlap syndromes की बात करो
Overlap
ना,
syndrome.
AIH plus PSC, AIH में तो itching नहीं होगा,
Yes.
right? That's a hepatitis.
Yes.
That's primary hepatocellular jaundice.
Yes.
So you have to keep something like PBC, PSC, depending on the
Yes.
prevalence and sex of the patient. Though
Yes.
they should have longer history, so it
Yes.
doesn't come so high in your differential diagnosis. But if you have to put it, then you talk about overlap syndrome. It cannot
Overlap.
alone be AIH alone, right?
Exactly. So it would be very difficult to explain. There is a variant of AIH called AIH with cholestasis. Many people don't agree to it. But if you read through the guidelines properly, it is there, but hardly anybody agrees to it, right? So next thing, what was coming, just one thing I wanted to point out before I forget is that the slide you showed about the histology, that's not a Mason's trichome, that's a H&E slide, okay?
HNE,
Mason's
yes.
trichome has got a specific pattern, so you should
fibrosis.
know the different types of slide. How would you explain the edema the patient had? You said there was, I think, up to ankle or knee edema that was there?
There was only edema up to ankle, sir.
Okay, so what's the physiological basis of edema in this patient?
Sir, on the urine routine microscopy, there was not a significant proteinuria, and most likely it was just reactive, as there was extensive rash and peeling of skin. That might be due to only reactive edema, sir.
Okay, anything else that you want to keep?
Sir, sometimes drug-induced edema also. There are some drugs causing edema, but I think, sir, he was taking only valproate and lithium, since unlikely to cause edema.
Okay. So can we come back to you? I think there are some questions already there. So somebody's asked, what's the cause of splenomegaly?
On the evaluation, we didn't find any specific cause for the splenomegaly, because we have done the all the evaluation for any infectious cause of jaundice, but we couldn't find any cause for splenomegaly.
Let's come back to your provisional diagnosis that was there. You said that your predominant was acute viral hepatitis. You are, I think, hinting towards a viral hepatitis with a cholestatic phase, right?
Yes.
Okay. And the duration of history was how long exactly from the time of onset of jaundice and cholestasis, itching?
So it was the history of starting jaundice was only for 10 days only.
And
Jaundice
itching was how many days after the jaundice started?
Sir, he gave history of itching on and off only for last 2-3 days.
Okay, so the duration is around 4, 6, 7 days, right?
Yes.
So how common is this cholestatic phase of viral hepatitis to occur within the 7 days of onset of jaundice? Because that's your first differential that you had kept, right?
Yes, sir.
So how common is it to get cholestasis in the first week of onset of jaundice?
Sorry, sir, I don't.
So it's not a very common thing, you see. The cholestasis usually sets in later whenever you have a viral hepatitis in a prolonged phase. So with that in background, would you like to rephrase your differentials, your order of things that you have? So I think autoimmune hepatitis sort of by per se AIH goes out of it. Viral hepatitis within 6-7 days presenting with cholestasis would be a little difficult to explain. Would you like to keep any extrahepatic pathologies? Or something which is intrahepatic as well as extrahepatic? Okay, no issues. So your predominant differential diagnosis are still based upon your history. It's number one, viral hepatitis, number two, AIH plus minus overlap, and then you said the third one was?
Drug-induced liver injuries.
Why not Dili your first one? Because you've got a rash, which looks like a classical rash. So
Yes.
I know it's difficult. Things which are common should be kept common. But when you have got a presentation which is very simulant of some condition, why not the drug-induced liver injury as your first differential instead of viral hepatitis?
So actually, it was drug-induced liver injury was only a diagnosis of exclusion. That's why we keep the daily last option.
So other moderators, you want to ask something?
Dr. Kash, I would just like to answer one query. Someone asked about splenomegaly. Right, so a lot of drugs cause splenomegaly by various mechanisms. They can have direct effect, they can stimulate immune system, they can cause hemolysis. Some of them can even cause chronic liver injury and portal hypertension, right, which of course is not the case. So even, simple drugs like cyproheptadine and others have been known to cause, phenytoin causes splenomegaly. So, that splenomegaly can be explained by that part. As far as differential is concerned, I would definitely agree with Dr. Kash, though it's not common and we are taught to keep common diagnosis first. But with skin involvement, I think even if you keep Dili as first, a sensible examiner will not pull you up. Definitely.
Agreed. I think we have a question about is this seronegative AIH? So I think that would bring us to the serologies. If you could go back to your serology slide once.
Yes, sir.
So you've got an ANA negative, you've got an SMA negative, LKM, and IgG 2256. So somebody, they're asking you whether it's a seronegative AIH. How would you defend?
So to say autoimmune hepatitis, at least ANA and anti-SMA should be positive for type 1, and while anti-LKM1 should be positive in the type 2 autoimmune hepatitis. While
They are asking about seronegative.
Okay. Oh, sorry.
So in that only IgG will be elevated. All the markers will be negative. So in this patient, basically, as Sir mentioned previously, that the pattern of liver injury was not hepatocellular cholestatic. Second thing, the liver biopsy was not quite suggestive of autoimmune hepatitis. And seronegative autoimmune hepatitis, I mean, very less likely based on the liver biopsy, Lft pattern, and patient presentation. Let's see.
Per se, if you would ask me, given the presentation, given the LFTs, I would not have kept AIH as a differential in this case.
Yes. Yes.
After I've seen the reports, and even if you see the trend of your LFTs, could you go to a LFT slide?
Yes.
See, there's already a spontaneous decrease of your alkaline phosphatase, and I think steroids you had given on the 28th, you said, right?
Yes, sir.
28th. See, on the 29th, your ASTs, ALTs, and this trend is already done. Okay, so sort of coincident with it. Okay, given on these, when you did the biopsy, what was there in your mind when you're doing the biopsy? What were you thinking to get in the biopsy?
Sir, as the medication, tablet valproate and lithium were already stopped, and even after stopping the medication, the follow-up LFT was not as much as expected. That's why, and the ALP and GGTP were predominantly raised. So that's why we to confirm the diagnosis and to rule out any to confirm the diagnosis, we were thinking of liver biopsy.
What were your differential in your mind? You have got your investigation, your labs are there. So what were your two things that you're worried about, two or three things, whatever is there, which you wanted to, because for drug-induced liver injury, if you know that there is nothing specific that a biopsy tells you. It's just like a Pandora's box. Anything can be there, anything like anything from hepatocellular necrosis to cholestasis to bile duct injury, anything can be there, right? So if you're not having any other differentials, then you could have just let it settle down by itself. Why not?
Only, sir, to consider initiation of steroids, and we were considering liver biopsy.
So that brings us to the point. So you gave this patient steroids, right?
Yes, sir.
So what in the biopsy made you convinced that this patient would need steroids?
So, as it was showing the predominantly eosinophil and suggestive of drug-induced hepatitis, drug-induced liver injury, the main management of drug-induced liver injuries, first of all, mainstay is to stop the impending drug, and the second on, if there is persistently deranged LFT, we have to give steroids and look for the LFTs. If there are decreasing in trend, we have to continue the LFTs, and if there is improvement of clinical situation and decrease in the LFT, we can continue up to the resolution of the symptoms and improvement of LFT until up to the improving of LFT.
So besides your biopsy and your LFT, would you have liked to specifically in this case, because you have some other features also, would have liked that more towards those? What is the standard treatment for DRESS?
So for the standard treatment of DRESS, there are recommended only to stop the causative drug, and there other things are still under investigation. That includes the N-acetylcysteine management with the N-acetylcysteine, giving steroids until the resolution of clinical symptoms and improvement of LFT, and the ursodeoxycholic acid. These are the only recommended management till now for the DRESS syndrome, and only there is a recommendation of undergoing evaluation for the cyclosporine in the case of DRESS syndrome.
So I think there are some stepwise approaches that are there to evaluate and manage DRESS syndrome. There's evidence with lots of.
So 2 points I would just like to chip in. The reason for starting medicines are, one, as he mentioned, that the LFT was not improving. Second thing, which was quite important, was that the PT-INR, the INR was deranged of this patient. And third thing which was not improving. And third things are, we had a discussion on this in the department and with the other departments also, like oncology. So there was one thing which was quite noticeable, that the eosinophilia, I don't know, I'm sorry whether it is mentioned or not, the eosinophilia was increasing, sir, in this patient. So that's why we had decided to start on steroids after seeing that.
That's why I agree. More than the liver biopsy per se, I think the overall clinical picture fitted into, because I don't think there was much in the biopsy to say that you would benefit from steroids. Anyways, drug-induced liver injury biopsies are always like this.
Yes, sir. And the liver biopsy, the features were not suggestive of, I mean, any severe activity. Like there were no prominent neutrophils, there was no portal venopathy, no severe fibrosis or hepatocellular necrosis was not there. But just because, sir, as you pointed out, the overall pattern of the patient.
Right. I think we'll take up some questions which is there. So Dr. Kamlesh has asked 5 to 6 portal tracks are sufficient for adequate examination of liver biopsy. He's asking about the.
No, sir. Ideally, there should be minimum 10 portal tracks for the liver biopsy to say it is a sufficient amount of liver tissue.
Okay. And this was a percutaneous biopsy that you had taken?
Yes.
Yes, sir. It was a percutaneous biopsy.
Okay. Okay. So Dr. Akshay has asked why the IgG levels were raised if it was a drug-induced liver injury.
Sir, IgG can be raised in normal individual up to 5%, and I don't think there is a relation between drug intake and IgG level increments.
See, that's true. We should take IgG levels in the context of the patient. IgG is immunoglobulin G. So any inflammatory processes when it is going on, there may be a raised IgG level. So unless it is taken into a whole context of the patient, it's very difficult. I see people jumping into a raised IgG and thinking it's seronegative AIH or AIH per se. It's very difficult to jump. You should see the entire conclusion. So raised IgG, does it actually go against this being a drug-induced liver injury? And how to explain thrombocytopenia?
As there was a splenomegaly, that might be the reason for the thrombocytopenia in this patient.
Okay. Anything else? Any other cause that you want to think about? Because see, the spleen was there from before, and your
Yes, sir.
platelets count have started dipping from say around about the 27.
Yes, sir.
So any other things that you want to bring in out here to explain the thrombocytopenia? Was he on any drugs in the hospitals which could have caused it?
No, sir.
Or was it the entire clinical deterioration of the patient that thrombocytopenia, when there is an overall clinical deterioration, there are associations of thrombocytopenia with it? Could it be due to that?
No, sir. I didn't find any cause for thrombocytopenia.
Okay. One last question. Why did you order a ceruloplasmin?
Sorry, sir.
Why did you order a ceruloplasmin? I saw in your investigation list one ceruloplasmin was ordered. Why did you order a ceruloplasmin?
Sir, actually, just to rule out other causes of CLD. That's all what we say.
Just for completion's sake, sometimes some examiners can be very finicky about it as to why, whether you're thinking that whether it's Wilson's and to order a ceruloplasmin specifically in an acute inflammatory state like this. So be careful on that. And I think if there is any other question, we are almost about to reach time. Okay.
I'll just like to say one thing, Dr. Kash. We were talking about IgG. So even certain drugs like hydralazine, methyl dopa, and minocycline, I think,
Yes.
can cause AIH like Dili. So in these patients, IgG4 can be high, but they are not AIH actually. And once
Absolutely.
the Dili starts to regress, the IgG levels start to come down. This is just a theoretical thing I thought I'll share.
Yes. So somebody is asking Kunal Kumar Gupta, what was the AIH score in this patient? So we want to take out that simplified AIH score. How do you calculate it? Since you were thinking AIH?
No, sir. We didn't calculate it.
Okay. So I think it would be more than 5 as I see it. Maximum it would be 4 or 5, right? So why was an MRCP not done? I think you mentioned an MRCP was done, right?
No, sir. We didn't do MRCP. We have done only ultrasound and CT triple phase only.
Okay. And there was no biliary dilatation on your. So
No.
in
No, sir. No, sir. There was no biliary dilatation or no CBD calculi in the CT triple phase.
So Dr. Kunal Kumar Gupta again, which drug could have caused Dili in this patient?
So most likely, I think most likely it was a sodium valproate because sodium valproate or most of the studies on the sodium valproate are showing the incidence less than in the children's, but ideally sodium valproate causes the drug-induced delay with the latency of 4 to 8 weeks, and typically this patient presented with the around 4 weeks latency period. That's what I consider as a sodium valproate as a positive agent in this case.
But he was on sodium valproate for a very prolonged period, right?
So he was started on valproate 2 months back, but it was shifted to lithium in only 15 days back only.
So why not lithium?
Sir, lithium any drug can cause drug-induced liver injury, but I think the latency period and more cases are there showing valproate causing liver injury. That's why I would say valproate was the positive agent.
I won't jump the gun on that so fast, and to give us a address would be something, yeah.
Sir, I would just like to add, sir, actually this case was a diagnostic dilemma for us too, because as we know, sir, valproate usually causes, although the timeline did set in, usually it causes by 1 to 3 months, the daily cause by valproate is by 1 to 3 months, and this patient was taking since 2 months. The issue was the LFT pattern, sir. The patient in this case had a cholestatic pattern, and as per the literature, the pattern is it has three patterns. Either it can, the most common pattern is, sir, hepatocellular. Second pattern is, sir, in uncommon cases, ALF, and in third cases the LFT is mostly normal or only mild transaminitis with mainly hyperammonemia and clinical H. So, sir, in this case, I mean, we could not label, but since it was the inciting agent, and probably, sir, lithium is not a known, it has caused in uncommon cases, but usually the reports are of transaminitis.
Okay.
So it might be, we don't know, sir, to be frank, that whether lithium had caused a change in the LFT pattern, whether it was a idiosyncratic add-on agent, we are not sure about that.
And
So,
one Dr. Akash, just one last sentence. We were talking about thrombocytopenia for the DNBs. Lithium is well known to cause
yes,
thrombocytopenia.
true. Yes, I think that's what I was also hinting at, that whether there was any drugs which was, because mostly it is due to that, but again, systemic inflammation and all these things that can also explain this. So, could you calculate your RUCAM, and do you have a RUCAM for this? Whatever modified RUCAM we get, because we won't be getting an absolute RUCAM. So,
I don't think that was calculated.
okay, so we don't have a RUCAM.
No, we don't have a RUCAM.
Okay, anyways, RUCAM with all its own limitations, still I think we
Yes.
can. It's a very nice case. I think we have just hit time. It's 7 o'clock. So I hand it over to the board members.
Yeah, thank you very much, trainees and faculty members, for joining us.
Thank you. Thank you very much.